Sachin Tendulkar. That was Richard. Yeah, apparently, I'm supposed to know who he is. I know who he is, so don't worry. So don't hate me. Okay, very good batsman. Um, so essentially, so you can substitute the baseball for cricket if you want to, but if you think batted, and really all you're saying is that can this patient bathe themselves? Can they walk, ambulation? Can they go to the loo on their own? Things like transferring from the bed. Can they eat and can they dress? So that's the bare minimum active. But you can see it's not a lot actually, but that's essentially, if you can do all these things on your own without any help from anyone, you've got a good performance status. So the original, again, this is just to give you some historical context. Konofsky did the original work at really trying to scientifically look at performance status and in patients who were having treatment for lung cancer at the time. And what he basically did was he scored patients from 0, if they were dead, hopefully he didn't have too many of them, to 100, normally active, and their ability to perform these activities of daily living and the level of assistance that they needed. And that has kind of been the benchmark that oncologists now use to decide whether or not patients will get treatment, especially radical treatment. And this is his original paper, and you can see how he's listed all these various activities and given them a score, which is great. The Americans still use the Konofsky system in a lot, and a lot of oncology trials use 70 and above as their cutoff. So if you're 60 and below, essentially you're on your own, kind of. But we're a bit simpler in Europe. We like, and also we kind of adopt the ECOG. This was an American system still, the Eastern Cooperative Oncology Group, and they kind of shrunk all those various points into 4 scales, 0 to 4, and then there was a 5th point which they added, and essentially, 5 is dead, pretty self-explanatory. If you're a 4, pretty much you're fully dependent on nursing care. If you're a 3, if you just think about 50% of the time or more, you're kind of, in bed and needing a lot of nursing care. If you're a 2, you can get about, for more than 50% of the time, but you still need some care. If you're a 1, there are some restrictions on your activities, but you can go about normal day-to-day life. But if you're a 0, you're pretty normal. That's the way to look at it. And this scale helps you sort of compare the ECOG and the Konofsky scales together. So 0 and 1 kind of corresponds to 70 to 100. It's just a nice sort of visual representation of the numbers. So that's very important when I think what you guys need to take away from this is when you're presenting patients at your tumor boards, for example, or you're talking to your seniors about patients with a cancer diagnosis or undergoing their diagnostic pathway, you just need to remember to emphasize their performance status, because that already will set the scene for how this patient will be managed. So this just shows you some data on the relevance of performance status in cancer management. This paper looked at almost 1,000 breast cancer patients with a primary outcome of 3-year survival, and they found that patients with with more than 3 of 7 comorbidities were 20 times more likely to die from all causes other than breast cancer, and this was independent of lots of other potential factors. So comorbidities is important. Well, this is another paper looking at lung cancer patients, which showed that if you had a Charlson comorbidity index score of 1 versus 0, you did worse. So these are just a number of papers which we will skip through. That's another paper looking at the role of comorbidities and this is a head and neck paper, which again showed that if your Charlson comorbidity index score was high, it affected your overall survival. The ECOG status, though, was not associated with overall survival, but acted as an effect modifier between the two. It didn't affect cancer-specific survival, so that's another thing to take into consideration. So this is a good paper that I would suggest you read, because this specifically looked at assessment of comorbidities in surgical oncology, which is important. And as you know, surgery is the mainstay for many solid tumors. I like to wind up my oncology colleagues because I tell them, surgery is the best treatment for any solid tumor. Okay, if you have a solid tumor, the best thing you can do to it is cut it out and put it in the bin. Okay, that's the best thing you can do. Obviously, with a nice wide margin. And if you can achieve that without giving them any adjuvant therapy, any fancy drugs, all that radiotherapy, all that kind of stuff, you've done a good job. But obviously, for certain tumor types, that is not always possible. For example, in the head and neck, if I have a patient with a laryngeal cancer, yes, I can do a great operation, cut it out, put the larynx in the bin, but the patient won't thank me very much afterwards. So there are less radical alternatives to consider, okay? But despite that, we still have a job to do as surgeons. There are a number of treatments that tumor types we can treat. And in that context, comorbidities does have an influence in what we do. So, for example, in the context of therapeutic comorbidities, if I had a patient with what we call chronic obstructive pulmonary disease, a bad chest, that's the language that we as surgeons use because we're not very technical with all the medical terminology. So if you've got a patient with a bad chest, it may affect the choice of curative or radical treatment that we give them. So that patient could have been a candidate for a partial laryngectomy, where we're able to preserve part of their larynx so they could still speak and still swallow normally. However, if they've got bad lungs, they're at risk of aspiration pneumonias, and that could actually make their comorbidity worse. So you can see how comorbidity is actually influencing the extent of surgery here. Hence, patients with comorbidities are more likely to receive non-surgical treatment, which in some situations may be suboptimal. So you do have to take that into consideration when you're reading papers on the influence of comorbidities on overall survival. You actually do need to ask the question for that particular tumor type, is it because they were actually getting suboptimal treatment? That's the reason why the comorbidity was actually a significant factor in the overall survival. And this is a good paper which looked at patients having a choice of either surgery plus adjuvant radiotherapy or chemoradiotherapy for stage 3 laryngeal cancer, and they found that those with severe comorbidities tended to have radiotherapy, and they had a worse 5-year cancer-specific survival. Likewise, this is a Danish paper looking at a number of patients, over 5,000 patients with ovarian cancer, and they found that, again, those with severe comorbidities and advanced stage tended to be biased towards non-surgical treatment. So comorbidities can have a number of an impact on surgical outcomes because, as you know, if there are a number of comorbidities, it could affect their postoperative stay. And this is looking at patients with ASA. This is the American Society of Anesthesiologists, grade 3 and 4. So these are patients with severe systemic disease or disease which is a threat to life. And 45% of them died within 30 days. So you can see that's quite significant. We now move on to prognostic comorbidities, and that's where the comorbidity itself affects overall survival, or the side effects might be of treatment might exacerbate it. And in these are patients with non-small cell lung cancer, and the rate of death in those patients with significant comorbidities was much higher as a result of the treatments as they had. These are patients with breast cancer, again, more likely to die as a result. And what you need to think about in the context of postoperative outcomes and comorbidities, do you know who this is? Okay, this is the Great Britain cycling team, best in the world. And do you know why? Do you know why they always win? Who watched the Olympics? 2012, did you watch the Olympics? Okay, you didn't watch the Olympics? I know India's not always great in the Olympics. Is that why? Is that why you don't, you turn off the TVs when you, I should be careful what I say, I want to come back. So, but see, I'll tell you about, the Great British Olympic team have been winning gold like almost it's become boring now actually when you watch, you know, this is the World Championships, the Olympics, any race they enter, they always win gold. And it's, you know, everyone just says there's no point even watching. And the French, obviously, they get upset. They always blame foul play. So they, at one stage, there was a rumor that the wheels were not round wheels, that they were square wheels. Okay, that's the reason why, you know, the English did so well, or they were using some kind of space-age material which was illegal. All kinds of stuff was being said because it was just incredible how every time. And the guy, David Beresford, he's the guy, he's the you know, Olympic team, British Olympic team, I think overall boss. And what he did, I think, when he took the team from mediocrity, when they weren't winning anything, to world domination, is he just sat down and he said, look, how can we refine small things? And the principle was, if you can work on little things, when you add them all together, you have a big gain. So it's this theory of marginal gains. So things like the helmet is specially designed for its aerodynamic abilities, the jerseys, you know, the way that the bicycles are greased, all of these things all add up to increased performance. And it's the same principle that we've kind of tried to use in surgery with enhanced recovery, whereby we say, well, look, how can we fine-tune lots of little things to improve the outcomes of our patient? And this is just one paper looking at elderly patients with who had colorectal surgery. And when you do things like make them stop smoking, you know, improve their nutrition on the day of, before they come for surgery, give them a